this is a technique that you can use for your patients that come to you complaining of tennis elbow or lateral epicondylitis. A lot of people, they treat the main wad of 3, the musculature for the tennis elbow for their patients, and some have great benefits and some do not. And this is going to address some structures that I think some therapists are maybe missing in their treatments. And hopefully you can incorporate this into your treatments with your patients and see some benefits. So first off, what I'd like to do is show you guys a little bit of the anatomy for the ligamentous and the capsular areas of this tissue that we're going to be contacting and treating. Now right here we have the radial collateral nerve, and if you notice it has actually 2 portions to it. There's a lateral portion and there's an anterior portion. You can see that it actually blends into the joint capsule, which meets with the annular ligament of the proximal head of the radius, and which comes off of the ulna on the posterior aspect and attaches onto the ulna on the anterior aspect. So when we're treating, we want to be able to increase a bit of a gap in that humeral radial joint, and we want to increase or try and influence a little bit of a change in the environment and an increase in length of that radial collateral ligament. We also want to check the force coupling mechanism of this proximal radial head. And what I tend to see is that we have to remember that there's a supinator muscle that sits over top of the radius and the ulna that actually blends in series with this annular ligament and this humeral radial capsule. With the supinator, we have to remember that we have a superficial and a deep nerve of the radial nerve that runs through here. We have the superficial nerve of the radius that runs over top of the supinator, and then we have a deep branch of the radial nerve which becomes the posterior interosseous nerve of that nerve. So when we have patients that complain of tennis elbow-like signs and symptoms, and they complain of sort of a deep ache through their forearm or through their interosseous, it's usually because that supinator muscle is causing a compression on that deep interosseous nerve, and it's creating that referral pattern. So we really want to change the environment through this area, increase some space in through that humeral radial nerve, sort of restore the force coupling mechanism of this proximal head of the radius, and then loosen up or change the tension and the tone of that supinator muscle, decreasing the compression on that interosseous nerve coming off of the posterior portion of that radial nerve. So let's have a look and see what the treatment looks like. So here we have Lee Aaron's elbow. Lee Aaron is a massage therapist. So as with all of us, these tissues tend to get overused quite a bit. So what we like to do first is find that proximal head of the radius, have your thumb located on that. We like to take the distal end of the radius with our thumb and index finger, and we sort of like to slowly try and take this radius into a position of pronation. And what you'll notice is that if there is a bit of a resistance going into pronation, typically the tone through supinator is increased and it's holding it into a supinated position, which is causing that resistance going into the pronation. So a lot of therapists are really good and great at working at the proximal wad of 3 in through here, the common extensor tendon. So what we can do is we can just do some fascial rehydration techniques. Remember that we like to use the term fascial rehydration techniques because the Steccos from Italy have produced research that shows that the fascial tissues are capable of producing a hyaluronic acid, which acts as a lubricant for these fascial tissues. And when tissues tend to become overused, overstretched, they tend to become dehydrated and they don't secrete the hyaluronic acid as much as they should, and tissues tend to get stuck upon one another. We have to also remember that the fascial tissues, the muscle tissues, joint capsules, ligaments, they all work in series with one another. They're not separate. So when we work on fascial tissue, we're actually having an influence on that ligamentous and capsular tissues also. So right now, I'm just slowly and gently going through this common extensor, really picking it up from the posterior aspect of it, and with my thumb and my index finger just trying to increase some elasticity in through the tissue, and I'm just picking it up away from that radial collateral ligament and from the annular ligament also. Be aware that as we get close to the origin site off of the superior aspect of this lateral condyle of the humerus, that I can get a little bit stuck. It can be a little bit tender, especially when it's sort of in a acute or a subacute flare-up. So just be aware of your patient's discomfort tolerances, and you may want to communicate that information to them. So now that we've got some great elasticity and mobility through this tissue, we want to, again, assess how that annular ligament and that proximal humeroradial joint, what the force coupling mechanism is like through that. So with my thumb, I'm just at the very proximal end of the head of the radius, and I'm going to slowly take the radius into pronation. I'm just going to monitor what happens with that joint. It moves a little bit better since we've loosened up that common extensor tendon, but it could move a little bit more. So all I'm going to do is just with my thumb, I'm going to load into that proximal head of the radius, and we're going to slowly encourage that motion into pronation. When I hit, or when I make contact with a point that seems like there's less elasticity, then we're just going to hold this position. We're going to let the change happen through the nervous system and through the physiology of this tissue. And as I gain some movement through here, I'm slowly going to continue moving the radius into pronation. And we're going to do this a couple of times. Now, if you find that you're not quite getting the range that you were hoping for, then what you can do is you can go to that supinator muscle, and you can utilize your fascial rehydration techniques. Remember that you should communicate to your patient that they may feel a little bit of numbness and tingling while you work through this area, mainly because of the compression on those two aspects of that radial nerve. And what I like to do is I like to just come off of the ulna and work towards the radius. If you're questioning if you're on supinator or if you're on another structure, what you can simply do to find supinator is take your fingers over top of where you think the supinator is, take your patient's hand into pronation, and then 1% only just try and supinate your hand. And as soon as she does that, it pops out supinator right over top of where I was working. Just a nice, easy way to landmark supinator. So I'm starting to get some nice elasticity and a decrease in tonus in this muscle. So we will double check the force coupling mechanism for the head of the radius. And that's starting to move a lot nicer now. And the last thing that we're going to do is we're going to make a change to that radial collateral ligament. Remember that the radial collateral ligament runs from the superior condyle of the lateral aspect of the humerus, runs down and attaches onto proximal head of the radius, joining in the joint capsule with that annular ligament. So to make a change in it, we really want to try and increase a bit of a gap in through that space and decrease any kind of compression that is occurring in through there. So I want you to find the distal end of the humerus. You're going to have your other hand at, the distal end of the humerus. You're going to have your other hand at the distal end of the radius. And we're really going to be using this aspect of our palm to feel that gap that's going to occur at that humeroradial joint. And all we're going to do is lock our hand, our hand that's at the distal end of the radius in place. And with my left hand, what I'm going to do is make sure that I can get a good grasp of the medial aspect and the lateral aspect. And then I can take her arm and I can cause a valgus and a varus stress to it. Now when I pull gently towards me, I can feel that resistance in that radial collateral ligament. So what we're going to do is we're going to disengage and exaggerate the position of that joint. So we're going to disengage that compressive force that's happening at that humeral radial joint. We're going to exaggerate the length of that ligament and capsular tissue. That's going to stimulate a ligamento-muscular reflex and a neurological impulse. And we're going to wait for a change to take place in this tissue. And what you should feel when that change occurs is you should feel a decreased amount of strength needed in order to maintain the gap between that humerus and that radius. Remember that these are slow techniques and that it can take anywhere from 30 seconds to a minute in very chronic conditions where patients have had adhesions and scar tissue and dehydration happening in through these areas. It can take up to 90 seconds or 3 minutes. Everybody's different. There's a bit of a change there. So we'll come back out. We'll do a little reassessment. I think I can get a little bit more space created in that joint. So we're just going to hold that there. And that's let go. So slowly come back off. Take it for a little valgus varus assessment again. There's a lot more elasticity through that joint now. Come back to our start position. Find that proximal radial head. Slowly take it through a force coupling mechanism. Look forward to see how that pronation is. It's a lot better than when we first started, but there's still some work that needs to be done here. The supinator needs to be loosened up a little bit more, I think. But for now, that's a good demonstration of how to find this radial collateral ligament, how to find annular ligament, how to create a gap through that humeral radial joint, how to assess and feel for the force coupling mechanism in through this proximal radial head, and how to also work with the annular ligament. So try that on your patients that are complaining to you of tennis elbow or lateral epicondylitis, and I will see you in the next treatment.